Before I start, I'd like to acknowledge the Bidjigal people that are the traditional custodians of this land, and I'd also like to pay my respects to elders, both past, present, and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. My name is Lauren Clark, and I will be chairing this session today. This is our 12th morning tea with iHealthE series. So I'm not quite sure how many years that has been, but it's incredible to think that it's our 12th. And this is the second time that we're running in hybrid format. So welcome to those who are online. Jack, how many do we have on? 17 online. So welcome to those of you who are online with us today. So I guess these sessions are really an opportunity for us to share ideas, but also to build new connections or to consolidate existing connections. And I suppose with now iHealthE being here and integrate service building, really an opportunity for researchers, engineers and clinicians to come together as hopefully lead to some great clinical impact. So Tyree-IHealthE's mission is to co-create solutions that address real unmet needs in healthcare. I'm not going to read the next bit. I'm going to move straight onto the panel. So here with us today, we're very grateful to have Dr. Peter Sturgis, Melissa Leong, and Simo Jurisic. So I am going to read these, unfortunately, for you because I don't want to do our panel a disservice. Peter is a rehab medicine physician and director of rehab medicine at Prince of Wales Hospital. He is also a visiting medical officer with spinal outreach service. He has a research interest in applying accessible health engineering to address gaps in clinical practice for rehab patients. He is collaborating with iHealthE for use of virtual reality to supplement therapy for stroke patients, use of motion capture to improve assessment of upper limb impairments. Welcome, Pete. Melissa, next to Pete, is working as the health educator, occupational therapist at Prince of Wales Hospital, and her clinical areas of practice include upper limb amputee rehabilitation and pain. She's worked for over 25 years in both Australia and the UK and has a special interest in working with clients with upper limb loss to maximise independence using compensatory strategies, functional retraining and prosthetic fitting where appropriate. She's interested in working collaboratively with researchers and the multidisciplinary team to maximise the potential of innovative technology to enhance function. And at the end, we have Simo, who is a data visualization specialist with a background in game development. He has created interactive experiences ranging from theatre productions to wildfire simulations, and now focuses on VR, AR, so virtual reality and augmented reality applications for medical rehabilitation and training. At the iCinema Centre for Interactive Cinema Research at UNSW, he developed real-time tools for 360-degree immersive environments, and now works with ResTech and iHealthE to explore how game development can support innovative health solutions. Welcome, Simo. So very exciting group of people for us to be able to talk about assisting human ability. So the session will run where I will ask a series of questions and we'll have a discussion as a panel, and we'll throw to the floor to ask questions on where time permits. And then, of course, we can continue the conversation before afterwards. And Galbo, wherever you are, remind me that you have an announcement before I throw out to morning tea. Okay, so we're going to start. Ready? I think so. I think so. This is for the full panel. What I might do is I'll start with you, Pete, and we'll work our way down, and then I will cherry pick depending on the questions as we go. Right. I suppose, so the first question is a very broad question, and it is, from your perspective and experiences, what does assisting human ability mean to you?
That's a broad question. I suppose from our point of view, we as see patients change that.
Excuse me, could you speak up a little?
Yes, sure.
That's only online.
Oh, okay, sorry. So we see people generally along the course of their life, but it's usually a life-changing moment. New disability, essentially. So disability, it can be pretty confronting for people, especially if it's something that's new, it's older in age. People that have had it when kids are generally more resilient and they just, that's life. But I suppose going back to the question, it's very rewarding for us to be able to give back some independence and quality of life, returning to work or their roles as whatever they do as a husband or mother or carer. That's the most rewarding part. That's the question, sorry.
Yeah, so I think it's such a broad question. You could
Very broad,
probably
yeah.
say a range of things, but I think that's a great start to the conversation. So Melissa, it's over to you.
Thank you. Excuse me, I've got a bit of asthma, so I'm coughing a little bit. So please with me. I guess to add on to what Peter just said, it is about getting them back into the role that they had. So I normally work with amputees, and so it's very traumatic, when they undergo that, especially as an adult. And I think getting them back to their roles, whether it's a worker or a parent or a partner, and then getting them back to doing really basic things like self-care, functional training, a meal, things that we can do easily and we take for granted if we have two hands. And I guess human ability for me is what they want to achieve, and that's all the technology that we offer, but it's how we translate it into the technology to enhance independence. And I guess that's kind of giving them the ability to use technology that they need.
Excellent. And similar last.
So from my perspective, I look at it more from the how we can use technology to allow for like better training and stuff of like patients in a clinical sense. And from my perspective, it kind of splits into two areas, one being the clinical rehabilitation part and the other being our built environment. So from the clinical rehab perspective, it's about using tools to help people go through therapy in a more engaging way. So we'd be using tools like VR to create these more interactive environments that allow people to train like very specific motions like walking or balance or coordination in a more like gamified way. And so gamified meaning making it more interactive, making it more likely that people would want to come back and go through rehab again and try to improve from their previous sessions. So we can do stuff like score systems and giving live feedback based on how you're progressing. And that's for the clinical sense. And from a built environment sense, it's more about designing our spaces such that they accommodate for all the different needs of people based on like what kind of devices they're using for mobility and stuff like that. And so from that point of view, we want to utilize technology before the development phase even starts, from the design phase, how we can use VR to build the environments and do virtual walkthroughs of them to kind of be like, oh, are these doorways wide enough to like accommodate wheelchairs, or are the ramps accessible enough, or is this signage clear enough? And then taking that from the design phase and using it to improve how we build our environments and spaces. And yeah, how they tie together is kind of like if someone's going through rehab and then they go out into the world and discover that it's very difficult to do very basic things like navigate airports or navigate like hospitals and stuff, they become pretty demoralized and it can affect their rehabilitation. Yeah. Yeah.
Pretty from the next question, but I am going to ask it of Melissa and Pete. But I might start with you, Melissa, if it's all right, and just say if it's too much. But the question is really, how is technology currently shaping your work, and what kind of impact are you seeing in people's lives? The question has asked me to be prescriptive on which technology, but I don't want to do that. So you're free to choose technology in general.
I think technology is, I guess, working in the upper limb amputee rehabilitation space. There's a lot of robotics in terms of development of, robotic hands, elbows, wrists, shoulders, you name it. And I think everyone, when they first come to see us, wants the robotic hand. And, it is trying to understand what their needs are, what the robotic hands can do, but also help you ready. But would like that. So I think technology is very much in the forefront. I think with, the availability of the web and 3D printing and YouTube. So there's a lot of stuff. Trying to translate it into a safe health environment where we're prescribing equipment and technology that has been tested, has been used, has been trialed. And, we've gone through all the testings and we've done the research, but also meeting their needs because they've gone through a very traumatic event that we're supporting them, listening to them, but also guiding them into the right prescription. So technology, I think at the moment, that's the answer. And I guess what type of technology, that's the VR, that's the robotics, the myoelectric training, but it's not just the actual hands now. There's a lot of technology in the control systems as well. So that's a big move, towards looking at the person as a whole.
It's massive. I really think of 10 years ago. It's totally, even beds in the hospital are so vastly different. My clinical room has a manual bed where you need to lift back up, and now it's all electronic to save nurses' backs. They're huge changes that take, there's years of development by the geniuses in this room that actually make a massive difference day to day. Even blood pressure machines that automate rather than the nurses having to go back and enter the details. It's automatically done. It saves them time. From the inpatient setting, it's all those day-to-day things for basic nursing care. From the outpatient setting, then we're starting to think about these devices and technology to make life better at home, in the home setting, whether it's walking aids or mobility aids or prosthetic limbs. From the research side and from the rehabilitation side, and we're looking at the tech, like what Simo's doing, and we add to current or traditional practice, which is very hands-on, very purpose-led, but with limited technology. I think we should ever replace them. To replace all the contact is not appropriate, and I don't think it would go down that far, but limited time. There's only one Melissa Leon in the hospital in the state that covers the whole upper limb prosthetics. These things to make her job easier. That's where the solution.
They're brilliant. And I think what we've heard a few times is AR and VR. So the next question is going to move into, I suppose, specifically AR and VR. But before I do ask the clinical question, I wonder, Simo, if you can just, for the audience and perhaps for those unfamiliar with the two terms, can you provide a brief definition or compare the two, what augmented reality versus virtual reality, and then I'll ask the clinical question if that's okay.
So virtual reality is basically recreating an entire environment inside a virtual space. So you put on an enclosed headset and the real world basically goes away and you're in an enclosed virtual environment that you can walk around in. And augmented reality, or AR, is basically overlaying information onto the real world physical space so that you can both interact with the physical world and the overlaid elements of the augmented reality.
So with those definitions, Pete, I might ask you first, I suppose, how are these immersive tools like AR and VR changing the way patients engage with therapy? And are you seeing an improvement in outcomes? And perhaps that might be anecdotal at this stage, but depending on how mature the research is.
It's not new. I mean, people are doing virtual reality, immersive reality, or rehab. I think where a lot of the American companies and things that are working on it is very much models where they'll have a or a therapist that will apply the technology with a patient and then gets charged an hourly rate. It can be quite prohibitive. In the insurance model, I think it makes sense, but for Australia, we don't really have the same health system. It's not really equitable in terms of access. So where I think we need to go is essentially can be supplemented care or have a cost-effective and cheap, accessible technology that people can use. So what we're doing at Prince of Wales, combined with a lot of people along that creator in the audience, it's essentially a feasibility, a test study looking at immersive virtual reality in the acute setting with stroke patients in hospital, so on our ward. And it's not to replace therapists, it's really to add to what they do. So, not looking on our ward, but an occupational therapist or physiotherapist might spend a couple of hours in a day doing rehabilitation. Some vary, some will have less, some will have more. A lot of time in a day where they're not doing it. So there's a lot of downtime. We just don't have enough staff, enough therapy to be able to offer the patient in their most critical time where they need that repetitive movement. So what we're doing is a very simple program, and we're seeing a patient and their carers. In other words, not nursing staff. No staff, because we work time for it. They set it up. They put it on. They run through a simple program. That process involved. So we're looking at that from a process level. It's feasible. And then from that, we've got side-by-side project. We've got an honest student that Juno and I are both supervising, who's looking at more stroke-specific game to develop. And then we'll have hopefully an array or a suite of games that can be targeted for stroke. So far, we've only rolled it out in mild strokes with minimal cognitive impairment, and it's been very, very easy. But I think the challenge will be the ones who have severe cognitive impairment, whether that's suitable for them, because it may not be suitable for everyone.
And how do patients receive this type of therapy?
Do they like it?
Yeah, do they like it?
The ones that have trialled it are younger so far. So we're doing it in I suppose, the more likely to have received a good price, but we will put it through the whole cohort of stroke patients, but they've been on the younger side, plus not as cognitively impaired, and they've enjoyed it. I mean, the game, for those that don't know, is essentially Juno's created it, and Simo's made it very specific for our population, making it easy to done in bed, so the patients are in bed. It's very safe. It's not only upper limb movement recovery, so we're not looking at cognition and things like that. But the idea is that a wombat will appear, and they've got their hands, which are represented as gloves, like boxing gloves, and then when the wombat appears, they just punch the wombat. So hands. We don't need to it's fun. I mean, there's a few noise effects and things, so it's an engaging game. It's comical. No one's taken offence to it so far. But it has increasing levels of complexity. So it starts off at wombat's low down, not too far stretching out, and then it gradually gets higher and further apart. So they have to reach more, and it's a time-based element as well. So for the game is 30-second levels, and they need to hit a certain number of wombats to be able to progress to the next level. But we're not looking at the game; we're looking at the approach. But as a side effect from the game, they do enjoy it.
The context, I suppose, of upper limb amputation and prosthetic prescription. How is AR VR in a similar way or in a very different way?
So we have VR. They don't take it home; they actually do it in clinic. And so the beginnings of my electric would be testing their muscle size to see they have the control to opening close the hand. Sorry. So at the moment, traditionally, we set them up with my electric, equipment that we hook up to the laptop, and we can look at the muscle signals. But with the use of VR, we can actually translate that into a scene. So they, have to go and get a cup of water. So they actually operate the open and close signals to try and simulate a few tasks, which we've built together with the researchers. And it's good. And I think Simo said that it's about motivation and something different, because most of the time they won't really be able to try that until they get their prosthetic arm made. But in this case, you can try it right in the beginning when they're actually doing the early training. And I think it motivates them to then understand what the end point looks like, rather than sitting there the muscles to be executed. And it's good, like, you can do, like, I think we have a barbecue setting, like making a drink. And it is motivating. We're not at the stage of them taking it home yet, but I think everyone's been very positive. And I think the gaming aspect, Simo mentioned that as well. People are very competitive. And I think it's a really nice way of them competing with themselves, because a lot of these VR, there's a lot more data that we can capture. Time, accuracy, and then you can combine it. So I think all those things are very motivating, especially from a therapist point of view, so they just don't have to hear my voice all the time. They have something that they can aim for and something quantitative as well. So yeah, it's been useful with the training.
Thank you. So, yeah, and the next question, we're going to talk a little bit about motion capture. So probably most people are familiar with motion capture in the context of, well, I've got to make sure when I use this reference in 5, everyone's too young, but when Lord of the Rings was first produced and Gollum was animated, you would have seen, the actor with all the dots on his face, and then cameras recording the movement, and then those movements were overlaid on Gollum himself. Well, we can use that clinically or in a research setting to capture a lot of different information about how people move. So motion capture data can include things like joint angles, joint forces. We can combine it with EMG, so we can look at muscle activation patterns. There's lots and lots of data. And that's a challenge in motion capture. It produces a lot of numbers, a lot of numbers. Back in the day when Excel capped out at 10,000 rows, it often was not, you could not open it in Excel. So that's the scale of the data that you get from motion capture. So I suppose the next question is a bit of a tricky one, but and it's towards Peter and Simo. So Melissa, you get a little rest. And so the question says motion capture generates data, and a lot of data. And how are we using that information to better understand movement and guide treatment or device design? So Simo, maybe I'll start with you and give Peter a bit of time to collect his thoughts.
Yeah. So for me, motion capture is basically just another source of data that we can use to derive other data from. By itself, the motion capture data isn't very useful, but once you start deriving things like velocity and accuracy and how well people are doing during certain scenarios like exercise and stuff, that's where the real potential comes out of it, where we can start even adapting the scenarios based on how well they're doing. So if certain exercises are very frustrating, it's too difficult for them, we can start automatically adjusting those based on the parameters that we get out of the motion capture data, and so that they feel a bit more confident in their movements as they progress through those scenarios. And that's how I kind of see the biggest benefit of motion capture.
You can collect in a clinical setting, like walking speed, or perhaps stride length, those sorts of things. I suppose what is meaningful data from a clinical perspective?
It's a very good point. I think that was what I was going to say. What's meaningful?
Yeah.
What's clinically relevant? I mean, it is tricky. You've got so much data from these analyses, but I suppose that from our point of view, I think we would want something that's clinically able to be applied to the patient in front of you. That makes our job as clinicians easier is the nuts and bolts of it. But it's very, very useful because I'll tell you how archaic things are in reality. So in reality, we have the clinic, which is in the old part of the building, and if someone's coming through with either a lower limb amputation or they've got spasticity, this is just a gait, for example, we'll get them in the hallway, and the hallway might be from here to that window. And then we just say, can you just walk along there